A very, very warm welcome to the last in our series of webinars. Huge thanks to Greater Manchester Primary Care Provider Board for inviting me to do these webinars. I've really enjoyed them. I really hope that you have also enjoyed them, and perhaps even more importantly, that you found them helpful. So what I'm going to do today is to pick out the key insights from each of the 5 webinars I've delivered so far. Quite a tricky job to do, actually, because in the end it involved hundreds and hundreds of slides, but it did make me focus my thinking on what are the most important things people need to know. So that's what we're going to do. As always, I'm very, very happy to take questions. You will receive, everyone in Greater Manchester who comes under Greater Manchester Primary Care Provider Board will receive a PDF of the presentation as well. And as always, if there's anything that I or my team at Dentistry Compliance can do to help you, you only have to ask. And the last slide will show you how to get in touch with us. So we'll kick off now and then just recap on what we've done. We started out in November with a CQC update and avoiding common compliance pitfalls. We then moved to doing safeguarding and the Mental Capacity Act and looking at the CQC Mythbuster and what that had said. We moved on to infection control and I'll include elements from that. We then looked at gaining valid consent and the importance of keeping excellent patient records. We then did the very dry subject of IRMA and the amendments that happened in 2024. And then this is the last one. So I tried to pick out the most important things from each webinar. As I say, not an easy task, but quite interesting to kind of focus your mind. So we started out with a CQC, and this is what I started off by telling you, that the CQC had changed the way they assess all of health and social care. And this was the CQC definition, and then we looked at what that meant in English, which basically just really meant that they would be assessing everyone involved in health and social care in the same way. So that means care homes, GPs practices, dental practices. And that sounded like a jolly good idea at the time, but I now get, and before what they did before was do sector specific inspections. But I gather now, having tried out this single assessment framework, they are now reassessing that and most likely going to go back to sector specific inspections and ways of working with providers. Now, to be completely honest, I don't really think anything very much changed anyway, from a practices perspective anyway. One or two things did, and I'm just going to run through the things that did change and the things that didn't change. Now, whatever the CQC decides to do going forward, one thing is highly, highly unlikely to change, because they ask 5 key questions, all of which are really, really important. So they ask whether your practice is safe, whether the care you provide is effective, whether as a team you are caring and responsive to your patients' needs, and whether as a practice you are well led and you have good governance systems in place. So those will not change no matter how they decide to look at how they inspect. And so their new single assessment framework was all about quality statements and evidence, but it wasn't really any difference to what they looked at before. And I also mentioned when we first did this webinar back in November 25 that if you are doing all of these things really well, so you're providing safe, effective, caring, responsive care, and that you are well led and you're good at it, good will still be good, and that will not change. Obviously, it also means that that average will still be average, and some practices will still need improvement. Poor will still be poor, and dire will still be dire. And I shared with you this wonderful photograph of a practice I visited, which is a CQC photograph actually, but not mine. It's a practice I visited, and I can confirm that they had their Henry Hoover linked up to be their suction motor. Innovative, you might think. Compliant, definitely not. And dire, as was the rest of the practice. So the regulations are not changing. They will still be, whatever CQC decides going forward, they will still be governed by the Health and Social Care Act. So all of the things that we've had to do will remain the same. Also not changing is 10% of dental practices will still be inspected annually. These will either be risk-based, as in they've got a concern, or they will be random. And so we are the only sector they regulate that they don't publish ratings for. And the reason for that is because they only inspect 10% of dental practices a year. They say they will focus on practices that haven't been inspected for a long time. They don't qualify what long is. My opinion of that would be that it's anyone who has not had an inspection since 2014, when the regulations did change and the key lines of inquiry were established. Also practices that have never been inspected, and there are still quite a large number that haven't ever been inspected. Surprisingly, they have got that number down though, from a couple of thousand to around 400 to 500 now. So that's moving in the right direction. And they'll also focus on practices they have concerns about. So that could be a practice that there is a whistleblowing from, and that is alarmingly frequent. And actually, I was speaking to the Chief Dental Officer last week, who was telling me that there is more and more concern that patients are putting together complaints that have been written by AI, and I think that I'd be pretty sure that is the case, and I think that that is where some of the whistleblowing will be coming from. People get AI to write them a complaint, but if the CQC gets a complaint, they are duty bound to investigate it. Currently, how the inspectors assess compliance and draw their conclusions has changed. Before, there were a number of different ways that they could send you a response. What they send now is you've either met the regulations or you haven't met them all, and they draw those conclusions from the assessments. I think probably that is also unlikely to change. During that presentation, we also looked at all the pitfalls and how to avoid them, how you can get caught out in the mousetrap. And to do that, we looked at the top recurring areas of non-compliance, which we researched the CQC website to find out what practices are, where practices are stumbling. And also, we at Dentistry Compliance carry out mock CQC inspections, either in practice or remotely for our members when they request them. And so my data on what the top recurring areas are comes from the CQC and from us at Dentistry Compliance. And these are the most common areas. So we talked on the webinar in November about, actually I called it death by paperwork, which is probably a more accurate way of describing it. But this is policy overload, where practices have got so many policies that it's just impossible to stay up to date with them. Not only is it impossible to stay up to date with them, it's impossible for all the team to read and understand them. And we do come across that when we help practices with their compliance, and it does cause a lot of issues. So really important that the policies you have are the policies you need and not the ones you don't need. That should be obvious, but I think sometimes people get carried away and just have far too much because they think more is more. But actually, more is not more. and it causes all kinds of compliance issues. We talked about how quite often a common finding that we find anyway is that risk assessments and audits are inaccurate. By that I mean people have just gone through, say, the infection control audit and said yes, 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 without it actually being accurate. The other thing we see is that an audit's been undertaken, perhaps things have been identified, maybe on a fire risk assessment, something like that, but then there's been no follow-up, and that's very, very common. Incomplete personnel files, there's quite a big long list of things that you must have in everybody's personnel files, and bits of those missing. That's a common finding. That relates to governance. Poor compliance with safeguarding requirements, so that means that team members can't answer questions about how they would deal with a safeguarding incident, or they don't understand the Mental Capacity Act. Complaints handling issues, by that I mean that there is limited evidence that complaints have been handled in line with the guidance. Patient records issues, so that's very often consent issues, people not understanding what consent is, people writing the same things in every record. We'll talk about that a little bit more later on. Poor governance, that's the well-led category. So the two categories that practices most often stumble on in their CQC inspections are infection prevention and control, so that would be safe and well-led, which relates to governance. Also a common finding is emergency drugs and or equipment are out of date. So really important you have robust procedures in place to make sure that your emergency drugs are checked and your oxygen are checked very, very regularly, and so is your equipment. So those are the most frequent areas of non-compliance, and those are the things that if you're wanting to get your house in order, those are the things that you should focus on. We then moved on to do an update, a safeguarding update. I think that was in January this year, so earlier this year, and we looked at the CQC Dental Mythbuster 29 and the Mental Capacity Act. Now, just for your information, whilst the CQC is deciding on their way forward with how they're going to assess different sectors, they will not be updating the dental Mythbusters. So you will need to go somewhere else to check that everything is up to date. I think that's quite an important point, actually, because the CQC, the Mythbuster 29, which we've incorporated into all of our documentation, and it is great, but there are a few things now that have changed in March this year for safeguarding, which obviously the Mythbuster will not have picked up. So just be aware that the Mythbusters, which we could rely on before, are not as reliable a source of information as they once were. And I'm going to pick out the key things from the safeguarding presentation that I did for you. And probably the most important thing running through, well, the two really important things, this is one of the two most important things, is that it is the responsibility of every member of the dental team. So don't think, oh, well, that's not my job, I'm not the safeguarding lead, or I'm only the cleaner, or I'm only this, or I'm only that, so it's not as important for me. I think that thinking is very much something that I don't hear anymore or see anymore, did originally, but not anymore. Really important that everybody understands it's everybody's responsibility. But it isn't only our responsibility in practice, and it's a shared responsibility between all these different, these are called agencies, so social care, ICS, safeguarding authorities, the police, education, so schools, community health services, GPs practice, youth offenders team, and then your practice, my practice, and all dental practices, NSPCC, and all of these agencies have a responsibility in safeguarding. This is called multi-agency working, And when it fails, the consequences are, I put often catastrophic. I think I'm going to put nearly always catastrophic. And sadly, we continue to see horrific cases reported in the media of where multi-agency working has failed catastrophically, which is disappointing, to put it mildly, alarming. And it is a legal requirement for all of these agencies that I listed there to join the dots and not let safeguarding issues slip through the net. But it still keeps happening, and dots don't get joined and issues slip through the net. That means it's all the more important that we are very vigilant in our practices, in looking out for safeguarding concerns. In the Mythbuster 29, CQC picks out the fact that the risks to patients are higher where systems and processes, this is a quote from their site, processes are weak and staff don't know what to do when a safeguarding situation arises. This is really key. So I think having systems in place that mean everybody knows what to do when a safeguarding issue arises is really, really important. So make sure that you have a designated safeguarding lead. Not only will CQC inspectors expect this, it really does mean that you've got one person in the practice whose job and role it is as the safeguarding lead. Obviously, that's not their only role. It is to make sure that safeguarding is something that gets discussed on a regular basis. Just because I always get asked a lot about this, just a reminder about the different levels of training. So level 1 training should be 2 hours of verifiable CPD. Level 2, 3 hours of verifiable CPD. Level 1 and 2 can be carried out online, and training should be carried out at least every 3 years and should always be part of the practice induction program. So level 1 training is for reception and admin teams. Level 2 training is for clinical teams, and there is, of course, level 3 training as well, and that is largely for pediatric and specialist practices. Now, it has always been my very strong view that safeguarding should be carried out face-to-face and in your practice, with online training being an adjunct to this. And the reason for that is that it's all very well sitting in front of a presentation and learning the basics. But what really matters is, what would you do if this happened, if an issue came to light in your practice? And I'm really pleased to say that this seems to be the CQC's view too now, because just doing online training, again, personal view here, although I think the CQC does agree, is not really enough. So have a think about how you could do that. Why do I think that? Why does the CQC think that? It's because it allows you as a team to explore all aspects of safeguarding in a safe environment. And it also allows discussions on what you would actually do in practice if something came in, because you have to be prepared for it. A little bit like you have to be prepared for the patient that drops down dead in your practice, or has a heart attack, or has an asthmatic attack. It's really no different. And unless you keep it very high up on your agenda and you discuss what you would do, then just sitting in front of online training is probably not going to give you the answers that you need. Safeguarding leads. This is addressed to you, so you must ensure that all team members know how to recognise the signs of abuse, neglect and harm. We covered that in quite a lot of detail on the webinar. You must make sure everybody knows how to respond appropriately to a disclosure. That's where a patient tells you that something has happened or concern. You must know how to refer to the right place and who can help you, and you must record events accurately. Few hints and tips on safeguarding. Make sure that you have access to a copy of the Mental Capacity Act. Make sure you have a Mental Capacity Act policy, a consent policy and a restraint policy. We often get asked, why do we need a restraint policy? Well, actually, one of the mythbusters on CQC website is about when restraint is appropriate and when it isn't. So restraint policy, obviously, you must never forcibly restrain a patient. But there are instances when restraint is appropriate. So the patient that is trying to grab the local anaesthetic syringe or the air rotor, then a gentle restraint there would be appropriate, because you're preventing the patient from injuring themselves. And there are other instances in which restraint could be appropriate. So having a policy that lays out what is and isn't appropriate is a good thing to do. In terms of safeguarding and the Mental Capacity Act, make sure you provide team training, in particular related to the Mental Capacity Act. Make sure everybody understands the 5 key principles. CQC nearly always asks about the Mental Capacity Act, and they will ask everyone. So they'll ask clinicians, they'll ask dentists, hygienists, dental nurses. They will expect you to know what the Mental Capacity Act says. Now, back to safeguarding now. Consider practicing different scenarios in your practice. Anyone who attended my previous webinar will know that there are some scenarios in that, and practicing how you would handle that in practice is a little bit like practicing your CPR and basic life support routines. And do keep excellent clinical records. That's where you make sure everything is recorded relating to a safeguarding incident. Then the next one that we looked at was infection control. And actually, these are not CQC mythbusters, these are my mythbusters. And we turned it into something a little bit more interesting than just banging on about infection prevention and control, because everybody on this webinar today and out there in your practices will have done endless amounts of infection control training. So really just to have a look at some of the myths that perhaps still surround some things that we do. The learning outcomes from that presentation were, excuse me, quite a lot. We looked at the changes since the pandemic, managing cold sores, HTML 105, hand hygiene, immunizations, PPE, cleaning instruments, environmental cleaning, and management of healthcare waste and ventilation requirements. So how to pick out the most relevant things from that quite long list. That was quite a challenge. So what we did was we said, let's look at what I did for this presentation. I've picked out the things that I challenged you to say, is this true or false? So this was the first one. We can completely revert to pre-pandemic IPC. Is this true or false? Now, I've done this lecture a few times online, sometimes with voting and sometimes face-to-face, and I'm really delighted that the vast majority of people who have attended will agree that it is false, that we can completely revert to pre-pandemic IPC. So let's look at what has changed as a result of the pandemic. Obviously, we're talking in relation to infection prevention and control here, because the pandemic has changed so much as well. So at the start of the pandemic, we knew nothing. It was the blind leading the blind, practices were closed, and nobody knew what to do. Since the pandemic, I really believe we've become better at understanding, assessing, and managing clinical risks and also infection control risks. And I passionately believe that it is imperative that we don't forget the lessons that we learned and become complacent. So how did this all come about? Well, before COVID, we used what was called universal precautions. And these were not really universal, because what they did was they pretty much only focused on and protected, they were designed to protect against bloodborne viruses, and we never gave respiratory viruses a thought. So the main things that we looked at were Hep B, were HIV, and Hep C. And again, as I say, never giving respiratory viruses a thought. Along comes the pandemic, and suddenly we've got an out-of-control respiratory virus. And as we know, all respiratory viruses are transmitted through droplet and aerosol contamination. What do we do in a dental practice? We create lots of aerosol and we create lots of droplet. That's through speaking and coughing and sneezing and that sort of thing. What else do we do? Close contact, less than 2 meters with an infected person, we do that too. What else do we do? Touching recently contaminated surfaces. You might think, well, we don't do that in practice because we clean all the surfaces down that have had clinical instruments on them and so on. What about the door handles? Door handles, patient sneezes, they've got some horrible respiratory virus and they go to let themselves out of the surgery and they touch the door handle. Then people have degloved, go out of the surgery, and they also touch the recently contaminated surface, and that's how respiratory viruses get transmitted. So it did make us think long and hard, and I'm not going to go on any more about respiratory viruses here, but this leads on to conversations about ventilation and how we should do that. I'm not going to cover that here because we simply won't be able to fit everything in. And then here was another myth we looked at. It's okay to treat a patient with cold sores provided we're careful. Now, one of the reasons I put this into the infection control presentation is because we regularly get asked this. But I think certainly, again, it's been my very pleasant experience to discover that most people do actually know that it is not okay to treat a patient with cold sores, however careful you are, unless, of course, it is an emergency. And then that is different. But treating a patient with a very active cold sore, if you can avoid it, then you should. So cancelling or postponing, rather, non-urgent appointments is really important. If you do have to treat a patient with a cold sore because they've got a severe dental problem, then be very, very careful. Try not to use anything that creates an aerosol at all. Make sure that you don't have any exposed surfaces on your arms when you're treating them, and be very, very careful indeed with your infection control. But the rule of thumb really should be don't treat a patient with a very active cold sore. And indeed also, as a clinician or a other dental professional, so dentist, hygienist, therapist, dental nurse, also should not be in the practice really when they have a cold sore. So we talked a little bit about that on our webinar. Here was another myth we exploded. Now, the reason I chose this was because I think it's very, very easy to get complacent and think, well, and forget actually, you know, we were so good in the pandemic at washing our hands religiously. And I think we all know that vast amounts of hospital-acquired infection is transmitted by poor hand washing, infrequent hand washing, inadequate technique. And so it is completely untrue that hand hygiene is not as important now as it was during the pandemic. So the message there is continue with very rigorous hand hygiene, and try not to become complacent, try not to let it slip. I think it's very easy to become complacent and let it slip, but particularly bearing in mind this is not about COVID now, this is about all kinds of infections, bloodborne and airborne. So just be very sure that your hand hygiene techniques are very, very good indeed. And then we then looked at immunizations, and I asked the question, immunizations are not all mandatory. Is that true or false? Well, actually, this is one that is true. And so it is true. And the Green Book, chapter 12, is where we find out about what we should and shouldn't do in practice. The Hep B, as we all know, is mandatory, and for clinical team members. I would argue that it would be unwise as a non-clinical team member not to have Hep B as well. That, of course, is up to the practice and the person. But for clinical team members, GDC registrants, it is mandatory to have Hep B. That other list there, long as it is, tetanus, diphtheria, pertussis, whooping cough, polio, MMR, BCG, varicella, those are, the Green Book says you should have them. So that's not a must, it's a should. So I think really if you're thinking about protecting your team and yourself, then having those immunizations is important. And if you look at MMR, there's been a massive drop-off in people getting MMR vaccines for their children, and that has consequences. You know, we have sporadic measles outbreaks, and so I think, you know, thinking seriously about having those immunizations is a good idea. Might also want to be considering immunizations for seasonal flu. We've just come through a particularly unpleasant and difficult flu season, or not just come through, because we're now come through of a boiling hot summer. But certainly over the winter period, there was a lot of nasty seasonal flu around. And also a lot of RSV, actually, respiratory syncytial virus. My cousin ended up in hospital with this. So it's a very nasty virus indeed, and you can be vaccinated against it. Usually it's only people who are a bit older or who are immunocompromised in some way, but there is a vaccine for that available, and obviously for COVID-19 as well, which is still around and will always be around, as seasonal flu is as well. I mean, the flu that is around now is related to the flu that caused the Spanish flu years and years and years, dozens of years, decades and decades ago. Right, this is a time at which I'm going to just talk a little bit about PPE. So this was the Mythbuster I challenged you with. So surgery clothing, it's okay to pop out at lunchtime or stay in at lunchtime and travel in your surgery only clothing. Doesn't say only there. Is that true or false? Well, it is false. It is not okay to pop out at lunchtime, or indeed to eat your lunch or travel or do anything other than wear your surgery clothing in the surgery when you are in clinical sessions. So I'm not sure that's much of a myth anymore. I think everybody knows that now. In the very, very old days, I used to come to work in my surgery gear and go home in it, and probably also eat my dinner in it. Obviously, I wouldn't do that now because we know a whole lot more, I think, about infection control. And then while we're on the subject of PPE, making sure that PPE is appropriate. And actually, somebody told me yesterday about a patient who came in asking the practice, who's very immunocompromised, asking the practice if they would all wear FFP3 masks. So, and I would encourage you not to get rid of your FFP3 masks, because you never know when you might need them. Obviously, all the precautions, the transmission-based precautions that we had during COVID are not as relevant as they were. But as I said at the start, I think it's important that we don't learn the lessons that don't forget the lessons that we learned during COVID. And there may be times when you want to revert to slightly more stringent PPE. With respect to PPE, one of the biggest no-nos I see is people wandering around the practice, clinicians and dental nurses, hygienists, therapists, dentists wandering around the practice with their mask under their chin. So the mask must be worn over your nose and mouth and must be disposed of as single use. And actually masks are quite interesting as well, because I think we all thought before, I certainly did anyway, the pandemic, that actually they were really not particularly useful in protecting against bacterial infection. And the jury is out in terms of peer-reviewed evidence, but I think it is very much the case that there is evidence now that fluid-resistant surgical masks, when worn as single use and worn correctly, do actually protect you and the patient from respiratory infections. Here's another myth. Pre-sterilization cleaning is as important as autoclaving. Is that true or false? It is most definitely true. Because you can't sterilize an instrument that still has organic matter on it, whether that be blood or organic matter such as caries. And so removing organic matter, blood, caries, and so on from the instruments by pre-sterilization cleaning is as important as autoclaving. The method of choice is a washer disinfector. All of the methods are acceptable. The method of choice is a washer disinfector. Number 2 choice would be an ultrasonic, and number 3 choice would be manual cleaning. Now, interestingly, HTM, or interesting to me anyway, interestingly, HTM 0105 does allow manual cleaning. The reason it's interesting is because the BDA A12 document that preceded HTM 0105 heavily discouraged manual cleaning. The reason for that as the only method of cleaning. The reason for that is that it's very difficult to validate and it's very difficult to reproduce. Whereas with a washer disinfector in particular, you can validate that it is working. And gone are the days when they broke down all the time and they were really pretty useless. They are good now, and certainly they are the method of choice. They are also expensive. So, and if you are practicing in England, they are not a requirement unless you are setting up a new dental practice as a squat or carrying out significant refurbishment, in which case you should be putting into place HTM 0105 best practice, which involves having a washer disinfector. Ultrasonics are also acceptable. Make sure that the cycle is not interrupted. Ideally, you would want one that doesn't allow you to interrupt the cycle. But those versions are quite expensive. So a traditional ultrasonic is also acceptable. It's not as good because you can interrupt the cycle. Just make sure that your practice protocol, your infection control protocol, makes clear that the cycle must not be interrupted. And then there's manual cleaning, and you must monitor the temperature of water, and it must be below 45 degrees C. So those are the 3 methods of pre-sterilization cleaning. When you've done whichever method that you choose to use, then please do inspect the instruments with an illuminated magnifier. And if there is still debris on the instruments, then please re-clean them before you autoclave them. Really, I am hugely in favour of trying to cut down on single use items where we can, but things like a metal matrix band, you're never going to be able to clean, and they are marked as single use only. So those do need to be single use. Other things you may choose to try and find alternatives to that are not single use, and they are autoclavable. So that's a little bit on that. Environmental cleaning. Now this is quite an interesting one. I did a webinar lunchtime yesterday, and we were chatting this through, and really talking about how this is not necessarily always done as well as it could be. So the myth is that the question is, can environmental cleaning be done by anyone with no special training? It is not true that environmental cleaning can be done by just anybody. And obviously a lot of practices do have, it's done by a member of the team. That's not a problem in itself. What you do need to make sure, though, is that the person that does the cleaning has documented and appropriate training to undertake the cleaning. Special training is needed, and you do need evidence of it. And if you have a cleaning company come in, then you should ask to see the evidence, the documented evidence that the cleaners have been appropriately trained. So that is most definitely not true. We then moved on to looking at gaining valid consent and the importance of keeping excellent patient records. Now, I couldn't join you for this one. I had a funeral to attend, and my colleague at Dentistry Compliance, Bilkis Hussain, who is our head of compliance, took the webinar. I wrote it, but she very kindly delivered it. So let's just pick out the things that are important from that. And I think what I'd like to focus on, rather than masses of detail on patient records, really is valid consent. And I still see enormous amounts of misunderstanding over what valid consent really is. So we looked at on the webinar where it goes wrong, what the pitfalls and dangers are, what the roaring tiger is, and how you can avoid them. So let's start then with what valid consent is. So it is consent given by a patient prior to commencing treatment. So I have had cases where I've had to try and help dentists who have got retrospective consent, one dentist told me, which really is not a thing at all. So prior to commencing treatment, when the patient has enough information, that they understand, and that is the key to valid consent. The patient, in order for consent to be valid, the patient must understand the information. And the information will be about what their problem is, what their treatment options are, the risks and benefits of the treatment options, including the risks and benefits of doing nothing in some cases, and what the costs are. And if the patient does not understand any of that, then the consent you have is not valid. Be aware that patients can withdraw their consent at any time, so always a good plan to check during treatment that you still have consent to proceed at every stage of the treatment. So if you're doing a two-stage root treatment, that patient comes back for the second stage, then just check that you have consent to proceed to finish the job. So okay to proceed today is all you need. You don't need anything written, but you do need confirmation from the patient that they're okay to go through to the end of their treatment. So valid consent often gets confused with, and people use this term a lot, and actually even the GDC uses it, when actually it doesn't really exist. So consent is either valid or it isn't. And certainly valid consent is not the same thing as informed consent. And the way I look at it actually is informed consent is, even though I've put there that it doesn't really exist, what most people mean by informed consent is that I give the patient a pile of information. So I have done my bit. I have transferred the information. And I now have informed consent because the patient has signed a consent form. Wrong, wrong, and wrong. So consent is either valid or it isn't. And if the patient doesn't understand the treatment proposed or the alternatives, or indeed the costs, then consent is not valid. And actually, all the patient has to do is say, yeah, I know I signed that thing, but I didn't really understand what I was signing, but I really didn't understand. And that's it, your case is shot. Now, I don't believe that you should keep defensive patient records and write reams and reams of book length notes. But I think we do need to get away from this myth that consent is a signature on a form. And it is what all the defense organizations preach, but I still see it misunderstood. So just to reiterate, consent is only valid when the patient has enough information on which to base their decision. You also need to add another bit into the mix, which is you need to make sure you have enough information from the patient about them to make sure that the information you're giving them is appropriate to that patient. By that, I mean checking their dental history, social history, medical history, to make sure there are there's nothing in that you need to know on which to base your giving of treatment options. So do ensure that you've got enough information about the patient as well. And do record all of this. Now, obviously, there is a move towards AI note-taking, and some of the systems are really good, some are not so good, but I think it is a thing that is here to stay, for sure. I think also there are techie ways of demonstrating consent as well. At Dentistry Compliance, we have a really fantastic tool for having an auditable trail that you've got consent. Very simple, very easy for patients to use, and does give you great evidence that the patients have understood what you've talked about. And then, as I say, the defense organizations, and I have also banged on about this for years and years and years, is that a signature on a consent form where the patient is just signing because they've been asked to, rather than because they understand, is not valid consent. And I'm sure many of you will have had the experience that I have, which is where I think I'm quite a good communicator, and I think I've explained something really well to the patient. I even think that that the patient has understood, and they go out to the desk and they say, "What did she say?" So clearly I had not explained it properly, or I had failed to check that the patient had understood. So that is the most important part of gaining valid consent. We talked then a little bit about keeping excellent patient records. You'll note I've used the word excellent and not just good. I think you need to aim high with your patient record keeping. And so what do you need to include? Well, I would put it down as you need enough information that means you can provide great care. It also that if anybody sees your patient while you're not there, maybe in an emergency or they move away, then the clinician seeing your patient knows what the patient has had done. I think record keeping has moved on greatly over the years, but I still think there are a few massive pitfalls in patient record keeping. So you need enough information to provide great care, or another clinician to provide great care. You need enough to demonstrate that you have valid consent, and should things go horribly wrong, then your records will help you with, good records will help you with complaints handling or litigation, which we hope very much nobody has to get involved in. If you do find yourself in that unfortunate position and seeking guidance from your defense organization, the first thing they will ask is to see your patient records. So how much information is enough? This is really difficult because it's a very long list. And how do you find time to do all of this all the time? The issue really with it is that the GDC doesn't differentiate between whether you see your patient on the NHS or privately. And, you know, if you've got half an hour or 45 minutes to record all this information, happy days. If you are working in a busy NHS practice, much more challenging. That is where your dental nurse can be immensely helpful at recording information for you, or indeed some of these AI systems as well. So these are the sorts of things that you need to be recording. The gold standard is the not called FGDP anymore, College of General Dentistry, CG Dent's guidance on patient record keeping. And this is what your records should include. So I'm not going to read it all out to you. The areas that we often see missing when we help practices with patient record audits are, we often see caries, perio and oral cancer risk assessments missing. If you've got caries or perio risk assessments missing, it's quite difficult to prescribe radiographs appropriately because they should be based on a risk assessment. So as I say, I'm not going to read all of those out to you. And then we come on to radiographs. What you must record, it's a legal requirement, is the justification, so why you've taken the X-ray. They must be taken at appropriate intervals, and we covered that both on this webinar and also on the IRMA webinar. Appropriate intervals does not mean every 2 years. Just because 2 years has passed, it should be justifiable based on selection criteria that, again, CG Dent publishes. So you must be taken at appropriate intervals and must be, you must have a written report on your findings. And bite wings taken is not enough to justify a written report. You should grade your X-rays either as A, acceptable, so you can see what you're looking for, or B, N, not acceptable. More information to record, so any special tests and findings. A diagnosis, I rarely see a diagnosis recorded, but if you don't have a diagnosis, how can you prescribe treatment? So important to actually articulate what the diagnosis is. Details of the options discussed, risks, benefits, likely prognosis, warnings, and your advice or recommendation. I think perhaps we've gone a little bit too far the other way of, well, it's the patient's decision. And yes, indeed, it is the patient's decision and must always be the patient's decision. But patients will nearly always say, and what would you advise? And I would say that as well. If a dental medical professional was advising me, I'd say, what would you advise? It is okay to give your advice and recommendation. And because the patients are not necessarily going to be the best people to be the final arbiters of what, yes, they make the final decision, of course, but I think it's very, very helpful, and it's allowable that you give your advice or recommendation. Treatment plan, accurate details of treatment undertaken, details of treatment declined and advice given, written treatment plan, if you need one, and any grumbles. This can be really important if you have a patient who's a difficult, challenging patient, and sometimes I think you can see a pattern in grumbles. So just record what they're complaining of when they come in. You know, if they say, well, I've got a little bit of a twinge here when I eat ice cream, then record it, and then also record grumbles like patient complained because they were being kept waiting. Just things like that. It just makes it easier if things escalate anyway, if you've got these things recorded. So when I talk about excellent patient records, I do not mean writing War and Peace length documents in every patient's record, the longest book, I think, in the world. Maybe not, but certainly a very long book. And I do see that. So I probably see a bit of a generational divide where people of my age keep too few records, and people who've just qualified because they're terrified of not recording enough put too much. Or worse, they resort to templates, templates that are pre-filled in, and think that that will be a get out of jail free card. It is not. And if all your patient records say the same thing because you've used a template and you have failed to adjust the template, then I think that will spell it's a very dangerous thing to do. And then I think audit your patient records. I would encourage clinicians to do that themselves, because you're the ones you're trying to protect regularly, and act on your findings. I think quite often we can think, oh, well, yes, my records are fine. And then you look back and you find actually you've got all kinds of, if you've used a template, then all kinds of inappropriate stuff is in a patient's record. Smoking advice for 7-year-olds, that's a famous case where the template was not adjusted. So if you're going to use a template, then the best template is one that just provides a prompt rather than something that is pre-completed. Then we moved on and talked about IRMA, massively unexciting subject, which was amended in 2024, and it was what dental teams need to know now. So we looked at radiation protection in dentistry and split it into 5 sections. So we looked at the legal framework. We looked at who is responsible for what and what must be recorded. We looked at quality assurance, diagnostic reference levels and audit, and we looked at incidents and learning. And the 2 legal frameworks that we talked about, and these do sometimes get confused, so just for complete clarity, IRMA, ionizing radiation medical exposure regulations, focuses on protecting the patients, and in addition to the patients, also carers or comforters who need to be with the patient when the radiograph is being taken. So that's about patients basically, and comforters and carers. And IRR 17 focuses mainly on protecting your team members, protecting members of the public, protecting visitors that come to the practice. So that's things like making sure that you've got lead-lined, appropriate lead-lined walls, and all the other things we do to protect, and protects the patients as well. But primarily IRR 17 focuses on not on the patients, but on non-patients, let's call them. So why IRMA matters so much? X-rays are ionizing radiation, and we are always told that the risk for dental imaging is small, which it is, but small is not 0. So, and we do have a legal requirement to keep doses as low as reasonably practical, and that is called ALAR, so as low as reasonably practicable. That means that we have to take X-rays, of course we do, as part of what we do in practice, but it is absolutely incumbent upon us to keep those doses as low as possible. And there are a number of different ways of doing that. One of the most important ways of doing it is that you make sure that all exposures, all X-rays are justified. So you have a good reason for taking the X-ray. They must be authorized, they must be optimized, and they must be clinically evaluated. If you've taken a justified X-ray, but you haven't evaluated and you've never even looked at it, then that is a wasted exposure, and it is exposure that the patient needn't have had because you're not looking at it. Now, you might look at it at a later date, but that's really just not good enough. So you must be sure why you've taken the X-ray, what you're looking for on it, and then you must evaluate it and record your findings. So the record should show why the X-ray was taken and what was found. And as I say, it's not enough just to say, oh, caries found. You need to specify the tooth, caries, lower left 6, and what you're going to do about it as well. That's part of the clinical evaluation as well, because it might be that you record that there's an early lesion and that you're going to watch it, and that's fine. But I think making sure that there is a good reason for taking an X-ray and you can justify it, and it's not just, oh, well, I'm taking an X-ray because X-rays are due. That would never be justified. So you need a good reason for taking an X-ray, and you then need to evaluate it and have a report on what was found and then what you're going to do about it. All X-rays must deliver clinical benefits, and that the benefit will come from having useful diagnostic information. So by that I mean it should confirm a diagnosis, or it should give you information that you didn't have before, or information that is needed for treatment planning. And the way to reduce harm from the ionizing radiation is to make sure you have correct selection techniques, the right technique, and that you avoid repeats. And if you do those things, then you are keeping the dose to your patient as low as reasonably practicable. So it all goes wrong when perhaps there's poor technique, and so that the X-ray doesn't actually show you what it needs to show you. So you're trying to take a periapical and the apex of the tooth is cut off. That doesn't give you the information that you need and doesn't deliver clinical benefit. So then there was a change in 2024 to IRMA, not to IRR 17. So what changed in 2024? IRMA is now called and must be referred to as IRMA 2017 as amended. And the as amended refers to the changes that happened in 2024. And the changes might, to the uninitiated, seem like quite minor changes, but actually they're really quite significant changes. And there is a whole lot more focus on having written procedures, making sure your quality assurance really does do what it's intended to do, making sure that you have appropriate clinical audit, and also making sure that any accidental or unintended exposures, how you handle those, the procedures are strengthened. So unintended exposures would relate to the periapical you took that cut off the apex of the tooth. You need to see the apex of the tooth, so you have to take another X-ray. That is an unintended exposure. You shouldn't have needed to do that. So the procedures must identify duty holders. Talk a bit more about that in a moment. They must be clear about who is entitled to do what in your practice. Now, there is a lot more emphasis since 2024 on the employer's responsibilities. And when we did the IRMA webinar, I went through about 3 slides, I think, listing the employer's duties and responsibilities. I haven't included those here. Just know, though, just a reminder that the employer's duties have been strengthened considerably. You must be able to identify so the employer must identify the duty holders and be clear about who is entitled to do what in your practice. And in addition to that, the training records you have for radiography, radiology, radiation protection must reflect what individual people are entitled to do. I hope that makes sense. So the key roles in a practice are the employer. This is where, as I say, the employer has much more stringent duties. Doesn't mean they have to do everything themselves, but it does mean that their overall responsibility is increased. So the key duty holders are the referrer. So that's the person that refers for the radiograph, and it is that person's responsibility to justify and provide enough clinical information that shows why the X-ray is justified. Now, this could be within your practice, or it could be that you are referring a patient outside the practice, where it's important that you provide enough clinical information for the person taking the X-ray to decide whether it's justified or not. So the referrer must justify the X-ray and provide enough clinical information to back up the justification. Then you've got the practitioner, the IRMA practitioner, and that is very often the clinician in dental practice, and the referrer and the clinician and the practitioner could actually be the same person. And then you've got the operator, and the operator does a whole load of, can do a whole load of different things. And for all of these roles, referrer, practitioner, and operator, then there are different duties and different training needs. Then you've got the radiation protection advisor, the RPA, and the medical physics expert, the MPE. We'll talk a bit more about that in a moment. So entitlement records, this should then name the individual. So these are the, you name the duty holder, name the individual, define their role. So let's say it's a dentist. So name the individual. This is the person. Define what their role is. This person can act as referrer and practitioner and operator. The records should be supported by evidence that they've had appropriate training and that they're competent, and they should be specific enough to show within your practice who can do what. So it might be a dental nurse who has been trained to press the button to take the X-ray, but has not got the radiography certificate. Then that would name the individual, define their role. They can press the button, be supported by evidence that can be provided in the practice, and you should have evidence of competence as well. And so that then means that it is specific enough to show who can do what. Each role has its own duties, entitlement, and documentation, but obviously one person can hold one or more, or indeed all of those roles, and actually can obviously hold the employer role as well. So it sounds complicated, it really isn't. The radiation protection advisor and the medical physics expert often get confused. So the RPA, radiation protection advisor, advises on IRR 17 matters, and the MPE, medical physics expert, advises on IRMA matters. So that's on patient dose optimization, quality assurance. And also the MPE is the person you would consult in the event of some kind of accidental or overdose. And records should show appropriate support where relevant. So you have an incident perhaps, and they should show, your records should show what you did about it and how you consulted the medical physics expert. The RPA does things like provides you with local rules. They will check that your X-ray rooms are set up appropriately, or surgeries are set up appropriately with everything that you need to do to make sure you comply with the ionizing radiation regulations. Selection criteria. So how do you decide when to take an X-ray? The standard reference for this is the CG Dent document selection criteria for dental radiography. It is freely available to everybody, made available by CG Dent, originally written by FGDP UK, but now hosted on the CG Dent website. And it contains, it's very, very useful guidance on when you should take an X-ray, and for a huge range of different clinical situations. Now, if you decide you're going to do something different from what it says in the guidance, you must make sure that you can justify it and that the reason is clear. So what should your records show in relation to the radiographs you take. So it should show why the X-ray was needed, who justified it and authorized it, who evaluated it, what was found, what your image quality rating is, so that is acceptable or not acceptable, and any follow-up or action needed. That's just a little summary of what it should contain. So the image quality rating, that's changed recently. It used to be 1, 2, 3. It's now A or N. This should be recorded and monitored. And if you find that you are having a number of N images in the practice, so unacceptable images, then that should be reviewed as part of your quality assurance processes. So what happens when things go wrong? So you have accidental or unintended exposures. Well, these should be recognized promptly, and they should lead to learning and corrective action. And learning and corrective action is fine. What is really important, though, and that is important, is that you share the learnings with the team. And the aim of dealing with all incidents, adverse incidents and near misses, is always to find ways to reduce the risk of recurrence, because otherwise it's not surprising that things will go on going wrong. So you have an incident or a near miss, or something doesn't go as it should do with your radiation protection, then share the learnings with the team. This is what happened. This is what we're going to do to make sure it doesn't happen again. And sometimes the incident will uncover that additional training is needed. So perhaps you're having an abnormal number of retakes. I mean, you should never have a retake, of course. That's perfection. Perfection doesn't really exist. So the odd retake is probably justified. Patient moved. So there's a reason that you've got an X-ray that is not fit for purpose. But if it is a pattern, and this is why it's important to audit it, if it's a pattern of unacceptable radiographic images, then that, having been investigated, could uncover that the individual needs some additional training. But doing nothing is not an option. So what does good governance look like in relation to radiation protection? So you've got clear roles, you've got the duty holders, we know who the duty holders are. You've got sound entitlement. You should have an entitlement register that shows who's entitled to do what and why. You should have defensible justification for all of your radiographs and authorization. Each image must be evaluated. You must make sure that you have current written procedures. When I say current, they must be in line with the changes that happened in 2024. So a sure way of telling whether your procedures are up to date is by what you call what they're called. So if it's called IRMEI, IRMEI 2017 as amended, then they are probably up to date. If it's called something else, then they're probably not up to date. So that's quite a good way of checking to see whether your information is up to date. Audit, diagnostic reference level review, and incident learning that lead to improvement. So that's what good governance looks like in relation to radiation protection. So why bother with all of that? Well, it is a legal requirement. GDC requires you do it as well. And I discovered recently that the CQC has an IRMA team. And if the IRMA team, if a CQC inspector doesn't like what they see from a radiation protection point of view in your practice, they can call in the IRMA team, which sounds like some kind of SWAT team. And it may very well be. I don't know anyone who's had that happen to them, but I do think that it's just best to make sure you do things properly. And perhaps the most important reason of all, it's morally and ethically the right thing to do to make sure that we protect patients and teams and ourselves and the public from radiation they don't need to be exposed to, shouldn't be exposed to. Obviously, we all know that flying long distance on a plane, you've got more radiation from that than you'll get from a couple of bite wings. But I think just doing our bit to make sure that we keep doses as low as possible is the right thing to do. And actually, everything we've talked about today, and my very strong view of compliance generally, is don't do it because the regulators say you should do it because it's the right thing to do. And that's definitely one of my mantras. And this is another one. So put quite simply, if you don't have a compliant business, also known as practice, you don't have business. So compliance is really important. And it's also, I think everybody gets very, very hung up on their CQC inspection. So another favorite mantra of mine is that just like dogs are not just for Christmas, compliance is for life and not just for your inspection. And if you do have a compliant practice, then I can promise you, because we work with lots of practices that are compliant, that it will be less stressful. You'll have better motivated staff. You'll have people involved in compliance, involved in doing the right things. You won't have dramas, or reduced dramas anyway. And it is just a much better way to be operating, irrespective of what the regulators say. So, but I would say that because compliance is my passion. And of course, the biggest problem with compliance is you don't know what you don't know. And how do you know if you've got it right? How do you know if you've interpreted things correctly? How do you know if your interpretation is the same as the CQCs, or indeed in the same as the GDCs? As I say, compliance is my passion, probably the only dentist in the country who can claim that. Must get out more. But I think it's my huge privilege and pleasure to be able to help support practices with their compliance. And it's why I set up a compliance business in the first place. So really my message to you is I hope these webinars have been useful to you. If you would like help, how can we help you? What help would you like? We are always there to help, as are other organisations as well. And if we can help you in any way, then do please contact us. There's a QR code that will take you through to us as well there, and also a phone number, and also a website there. So if we can help you at any time, it would be our privilege and pleasure to do that. So that's the end of what I had to talk about today. I'm just going to have a look at the chat now and see if we've got any questions. I know we've got another 10 minutes or so until we finish completely. So if anybody would like to pop a question in the chat there, I would be really happy to answer that for you. Just give that a few minutes to see if anyone wants to ask me a question. As Rose has said, certificates and slides will be sent out when you filled in your evaluations, and that's worked really well. Is there any CPD for this? Yes, there is. You have to fill in your evaluation and you will be provided with a CPD certificate signed by me. Any questions? Anything? Compliance, regulation, GDC, CQC, anything at all? Well, either, no questions, so either that was all clear or everyone is now asleep in the 30-degree heat. So I will wish you all a good afternoon and a lovely summer, because we've now come to the end of our series here. And I would stress again, if at any time you need any help, we're only a phone call or an email away. So we'll finish there. Rose, thank you very much. And again, thank you to Greater Manchester primary care providers for asking me to do this. I thoroughly enjoyed it.
Thanks, Pat.